Hi, everybody. Now, if you've been working in the field of pelvic health, particularly women's health, in any regard over the past number of years, the name Sue Croft will and should be very familiar to you. Sue is the author of these fantastic books, which I think are essential reading for pretty much for all women, but certainly for people working in women's health. And Sue has, although she has been at the top of the field for many, many years, what I really admire about Sue is her commitment to lifelong learning. And we've been talking about some education that Sue's been participating in about really bringing in that field of psychologically informed care to our pelvic pain patients particularly, and really just trying to balance out the bio in biopsychosocial and making sure that what we're doing is not only psychologically informed, but also up to date. So, Ms. Croft, welcome. And
hello.
Excited to have you here. And thank you for joining me to talk about this, because I think this is a really important topic of conversation. In your career, how have you seen the evolution of the treatment of pelvic pain grow and develop?
Look, Michelle, I'm almost ashamed to think of how I used to treat pelvic pain, because it was really before I became a follower of Lorimer Moseley and David Butler's work with Explain Pain. I was really doing it from I don't know, I can't even think how I was doing it, because it was so transformative when I started reading Explain Pain. And so I think it was about 2008 that I got the book, and then in 2009 I did my first course. And I've actually done 4 of the Explain Pain courses. The first one was just the basic one, and then I've done 3 what we call EP3 courses, where it's a 3-day course, and every 3 years I've done that. And you know, I just like going to see them speak, but every time you're always blown out of the water by the amount of research that's happening. And I feel like it's one of those things that I will try and continue to do as long as we can do things in our new coronavirus life. So, I commend them to you wherever you are. And there are lots of people who take them. So even if you're overseas, there are plenty of fabulous presenters. And I think it just really does make the link between the biopsychosocial, where you're looking at the immune system and you're looking at how all the body systems play a part and can play havoc with how people perceive pain. So, I commend that to you. And I feel like when I did my first one in 2009, I was sitting in Tasmania in Hobart, and I had suffered all year with terrible plantar fasciitis, and I'd got it better. And David Butler started talking about how plantar fasciitis was a persistent pain condition, and I could feel the heel burning in my shoe, and I really literally wanted to get up and run out of that room. I didn't want to hear anymore, because it was so powerful, that the effect it was happening. And it was such a terrible year because I was on crutches and it was so bad. And so no one had ever said to me that it was a persistent pain condition. And so, that's the power of the brain. And I think then it just progressed on. What's happened, we went very quickly then to a biopsychosocial model of managing all our persistent pain. And I wrote a big handout based on, because Explain Pain wasn't really developed for pelvic pain. It really is for other regions in the body, but they've never really gone to the pelvis so much. And so we sort of adapted it to make it work. And that's just a constant work in progress. We keep looking at the handout every 6 months and keep up changing it. And as we get new things, we add things in. Then this year, on the recommendation of quite a few very well-renowned, high-profile pelvic health physios in Australia, and it was when I was involved in my role as co-chair of our scientific committee for the Continence Foundation of Australia conference this year, which I'll just give it a little plug, is actually
Absolutely.
coming up in October. And with your pound and your euro, you will, it's like, you know, having a cup of coffee almost. It's so cheap. So I really do commend it to you. And it will be in your time because it's at night in Australia. So it'll be your daytime over there. So it might be very convenient to people. But that's when Judith Thompson from Perth actually rang me and said, you know, I suggested Carolyn Van Darken as a speaker at our conference. And that's where I started to get to find out about Carolyn's work. And it really has taken everything to a new level. And I think it's really for the very complex pain patients, those who have had such a torrid story, and that might be from a very strong ACE background, so adverse childhood experiences, where there's been terrible things that have happened in their lives. And I really feel like we as physios must really acknowledge and understand and delve a little bit deeper into the impact of adverse childhood experiences when we're dealing with women who've got pelvic pain, and men and children. So I feel like, you know, when I started to read and talk to Carolyn, and then I did her course, and I got all my physios to do it because it was, I thought it was going to be good, and it was very good. It was very, very intense, and you know, my poor old brain is getting so to the point where, you know, I think there is a you know, the hard drive is getting a little full, but you know, you can just keep looking at things, and you can keep, and what we tend to do now is we give patients who are very complex, whereas Carolyn might send out all the screening sheets and do all of the screening questionnaires that she has talked about in the course to her patients, we are just choosing to give to those very complex patients. And then after we've done that first consultation, found out that story, we're then getting them to take them home, fill them in at their leisure so they're not too triggered by any of the questions that are asked, and then getting those questionnaires back and assessing them on their rating scale, and then deciding, well, what's important and what's standing out there.
So I suppose, like, you know, what I hear from a lot of physios is they're kind of thrown by what they feel sometimes is a shift away from traditional physio hands-on skills, looking for issues in the tissues, and maybe struggling to realize, you know, that everything that we have to do has to be psychologically informed, because we're working with whole people, with whole stories, you know, and histories. And to really get away from looking for that magic manual therapy technique that's going to maybe floss the pudendal nerve, realizing that issues like vulvodynia, that these are whole person issues. So is it a case that you know, you're not doing as much manual therapy or movement prescription, or do you find, because what I hear is, so I'm going to do my manual therapy, I'm going to do my exercise prescription, and then I'm going to do my pain science. And is there a way that we can really incorporate all of that into working with the person in front of us?
So I think the important thing is, Michelle, that we know from evidence that 1 in 4 patients will get a 50% improvement in their pain from simply hearing some pain science. Mm-hmm. So I feel like, you know, oftentimes when patients have got persistent pain, they end up being with us and they've had the runaround for 3 and 4 and 5 years. So, you know, there's no point in going in. They've had multiple MRIs, they've had injections, or they've had drugs, they've had everything, and really it's time to say all that stuff. You're not going to have better hands than someone else. It's just all that stuff. It's time to start looking and seeing, well, what is that psychological component that might be continuing to cause this pain to be persistent. And so I feel like, and I suppose when I started doing Carolyn's course, I was feeling nervous about the fact that because we're doing so many questionnaires, are we treading on the toes of psychologists? No. But to be honest, in Australia, there just aren't enough psychologists. And the other thing is that psychologists, like, you know, once you identify someone who might have something that is beyond what you feel comfortable in dealing with, then of course you can refer them on. But it is silly when you're talking to a patient. And I think that's the big thing. I think really starting to talk to them by listening. You know, these women need a really good listening to. And, you know, really, one of the things when they come to you, they are so hyped up. And I mean, as a naturally loud, noisy, bubbly person, I start right then by really, I slump back in my chair, I relax my belly, and I really just start talking very slowly to them when they're really, really, you know, sort of telling me about their story, about their pain, about their history, what happened with their mother, father, whatever. So what's really important is to understand that right from hearing that story, you have got to start implementing the things that we're talking about, that you're going to hear things that will ring alarm bells or ring things to say, this is a really important factor in this woman's story. Okay. And that might come from the fact, and if you're a listener, they're really dying to tell you, because I can think of some patients, and I think of someone who is never ever, and I'm seeing her at the moment, and she has had really about 15 to 18 years of persistent genital arousal disorder. So she has never told anybody about some of the things that she's told me, and that we've had long sessions, and I haven't touched her. I haven't laid a finger on her. I haven't looked at her backy. I've just sat there and let her come and talk. And I keep saying, how are you going? And she said, I just feel so, it's so cathartic to get this stuff off my chest. And so I think sometimes because of the terribly consuming time that it takes to get these stories, people don't want to go down that rabbit hole. But if you don't go down the rabbit hole, you're not going to actually unravel what's truly going on. Absolutely. So I think that, you know, understanding about the power of the psychology and the effect it has, a negative effect it has on your immune system and on your gut and your bowel and your, you know, everything is affected by these psychological factors.
But I think as well, though, Sue, like, wouldn't it be fair to say that as well as the listening and giving women, you know, time to tell their stories, but then being able to bring in, like you were saying, gut health and bowel health and sleep hygiene and movement strategies, but in a pain science informed way? I mean, aren't we actually treating the whole body when we're doing that? If we, you know, if we look at some of the science around gut brain interactions as well. And I think sometimes that's where physios can get a little bit lost, is that we're not saying that we want to be completely hands off forever, that we are actually going to work with bringing body and mind together. But we have to give time for the stories to be told, because our bodies hold all of that history. You know, every time, you know, your body is listening to every thought that you have. And
absolutely. And do you know what, the thing I always try and get into a conversation with a patient is that a thought is a chemical process.
Yeah.
You know, it's really important to understand that if you think about something and it has trauma associated to it, it has stress and anxiety associated to it, it has threat associated to it, then you're going to get a body reaction. You're going to get the autonomic nervous system responding in some way by release of a hormone. So if you have a nice, happy, joyous thought, you're going to have a positive hormone released. If you have a very negative thought and you're triggered to and react to something that might have been, you know, provocative to you, like you're listening to every night after night, the Royal Commission into child abuse in the church, you know, it was going on for 2 years here, every night on news. And all I could think about was those poor people who have suffered at the hands of someone who was supposed to hold a position of power and look up to them and respect, but, you know, and then they're not believed. So I think that it is terribly important to understand a thought is a chemical process, and that therefore we have to and thoughts become thought viruses. And so that's really lovely way to describe what I tend to do, and that's just because I've done it for 30 years, Michelle, is because I always ring the patient the night before, and no one else can do this. Like, I ring the patient the night before because I need the time to spend with them. And so I've already started to set the scene, because I get them to then go and read my blogs on pain. So I don't start confronting them with anything where I start mentioning the brain in that session. I've always encouraged them to read about the fact that there is interplay between the brain and the pain that they're feeling, and that in fact the brain decides whether you're going to have pain. And so that if we bring that concept in right in, and when they read, because they're patient stories, a lot of them, or they're lovely little 5-minute whiteboard videos, which are really quick. And if someone hasn't already read that, because it goes out on the email where they make their appointment, they haven't read any of those things, I get them to look at 3 things. I get them to look at the whiteboard video on what is persistent pain, which it's called What is Chronic Pain. Secondly, what are thought viruses? And third one is one I've written myself, which is called Sit Like a Man.
Yes.
And so when one of the things that, with the beautiful Jamie Fraser, one of the things I want to really bring home to patients when I'm talking to them is I want to give them, and this is good for physios when they're trying to remember, God, there's so much to remember. How do you remember it? Well, you want to make some sticky messages there so that they're really going to go out of here and they're going to remember some key things. And one of them is that the interplay between the abdominal muscles and the pelvic floor muscles and the muscles around the pelvis, in patients who we know there's evidence right back in 2001, Van der Velde, I've forgotten her first name now, Janneke van der Velde, did the research where she looked at the fact that these pelvic floor muscles, and I call them first responders to my patients, so that when you're hearing stressful news, when you're seeing something stressful, your pelvic floor is going to be contracting and tightening. Now, if you follow that on with being a young woman who we're always told we've got to cross our legs and be, no one can look up our dress. We've always got to have a flat tummy. So we're drawing on those abdominals. So we've got stress, anxiety, and we've got a whole lot of muscle groups that are tying in with the pelvic floor to make them be really non-relaxing. They're switched on all the time. And so if they have a pain experience, perhaps with putting a tampon in, or having their first speculum check, or having their first experience of intercourse, then that then starts to interplay with the brain in terms of memory. So the association starts to happen. And so I've forgotten how we got onto this thing, but yeah, let's just start talking it up. Go. Sticky messages. So the sticky message is that if we try and sit like a man, you know how a man sits in a train, his legs are apart, taking up 3 spaces on the train, his abdominal muscles are relaxed. And you know, coming back to the thing about always going to look for the physical thing.
Yeah.
You know, I apologize often to my patients and say, because when I say, come on, we're going to have a little slump here and we're going to sit back in the chair and relax, and they look horrified, and I say, I know it's okay, your SAJ will not go out, your disc will not slip, it's quite okay to do that. And we've been guilty of propagating that message for 15 years, and they look pretty shocked and disbelieving when I say, no, we're going to actually stop that one now and we're going to try this one. Yeah, it's okay to slump, it's okay to bend over, it's okay to do things, to move and change your position rather than holding a very rigid position. So that's where we've got to, you know, be okay to say, we got that, well, we misinterpreted the message that came out of the research and we ran with it wildly, and we're still running with it, and we're still trying to undo the damage from that misinterpretation of the research.
I think sorry, go ahead.
No, you go on.
I was going to say though, like, I think the message is that we do have to be careful though in how we're communicating all of this to the patients in front of us, because how many times have you heard pushback saying, well, if it is clumsily explained, she thinks the pain is all in my head.
Yeah.
That it's not real. And I think that's why
Yeah.
it's really key, isn't it, that we do talk about how, you know, it's not that you're damaged, it's just your brain is trying to protect you. It's sensitized, you know,
Yes.
the volume is turned
It's
way up.
about danger and safety, and safety, and how the brain perceives that.
Mm-hmm.
So if the brain is constantly looking at something that in a dangerous way, then there's always that's that thing. We've got to bring in that message that it's about what produces danger, and therefore the brain has to protect you from that danger, and what produces safety. What can we do? So it is very important. And you're right. I mean, it's hard work, and you don't ever start off by saying the pain, you know, it's all coming from your brain, you know. And I think the advantage of getting them to do a bit of pre-reading, and that's where probably you know, what the way that Carolyn goes about it is to send out a whole wad of screening sheets. And so I think the patients are filling those things in and seeing, wow, this is a depression, anxiety, stress scale. So there must be a bit of interplay going on here. And look, I've really, it's a real thing. And I've scored myself really high in the stress domain.
Yeah.
And so their depression might be okay. Their anxiety is not too bad, but their stress is really high. So what does that immediately say to us is when we're coming to talk about what are the broad strokes that we can do to help manage this? What are some immediate things? You know, tell me about how work is going. Tell me about what your out of work commitments are. How many talks are you doing, Michelle? And how many things are you having to help, you know, your members of the family with, and what is going on? Tell me about that, because you have rated yourself as being really high in the stress domain. So let's have a look at that and see, are there some simple things that I can help you with? And a very famous Irish women's health physio uses the term all the time of control the controllables at Ms. Lyons. And so, you know, a beautiful sticky message that I learned a few years ago from you. And I use it all the time, because if you have someone in your family who is unwell, you can't really control that. But what you can do is say, you know, I can control this other part of my life, which really needs a little bit of putting into the back burner. Leave that for the moment, because this part of my life is needing me, and that's a short-term thing that I need to address. And that taking that other part out will probably down-regulate a little bit what's going on if they're pain.
And I think that there's two really valuable takeaways from that, Sue. One is the destigmatization of mental health and the effect that mental health has on physical health. And you can't really separate the two of them. And to really acknowledge that it's a real thing, that if you have depression, anxiety, stress in your life, and of course we all do to some degree or another, but if you're not filling your own cup, you know, in ways that you can't continue to fill other people's cup either. You know, you have to look at strategies. Okay, so we can't change some of your life circumstances. Things just, you know, to quote somebody nefarious, it is what it is in certain areas of our lives. But what can we control? Can we control making good food choices? Can we control prioritizing sleep hygiene, finding enjoyable movement? You know, and I know you're a great advocate of dance as a psychological and physical tool. And really, I think that's one of the big takeaways, isn't it? That it doesn't all have to be very abstract, nebulous, you know. We can really bring it down into concrete things that you can do to start helping yourself, because, you know, and I think this might actually even be a quote from Carolyn, that vulvodynia is a whole person issue. You know, that we can't just look at the tissues of the vulva. We have to look at the person who's attached to that vulva, you know, and their story, particularly if there is, you know, if it's been going on for a number of months, there's going to be some sort of central component to that now. I think that only just to play devil's advocate a little bit with this, that we do have to acknowledge that there is still a bio in biopsychosocial. So for women with say, like endometriosis, You know,
Yes.
disease has to be treated as well as the psychosocial aspect of it. But so many women
Yep.
have a laparoscopic excision for their endo, and their pain doesn't necessarily always improve. You know, we look at that
No.
Fitzgerald study that came out a couple of years ago looking at myofascial treatment for chronic pelvic pain. And I think 59% of people got better with myofascial manual therapy. That means 41% didn't, because there was no psychologically informed adjunct to what was happening to them physically. So what I'm leading up to is, where does manual therapy fit into this? Can we have a pain science informed manual therapy approach where we're using our manual therapy to downregulate, to neuromodulate, and then give a gateway towards movement and towards self-efficacy?
So can you remember that? Because I just want to bring into the endo.
Yeah.
One of the, and I'll come back to that part about the manual therapy. One of the things that is like, we have Dr. Susan Evans in Australia, who is a very good pain specialist. And she started a program in the schools. So this is where the power of education comes in, that she's teaching girls at 14 that extreme painful periods, over the top painful periods, is not normal. So we all now, our audience knows that it takes 7 to sometimes 10 years to get endometriosis diagnosed. And so if the girls are told at 14, you know, over the top period pain, I've got some figures here because I won't remember it. So 1 in 4 girls in year 10 have missed school with period pain. 6% are having pain on more than 11 to 20 days is some of the research that Susan's done. 11 to 20 days out of every month.
Wow.
6% of girls are having pain such that they have an interruption to their school day, or they're just suffering pain. So if you get that at 14, every month, what are you going to think about? Oh my God, I've got the dance on Saturday night and my period's due. So that means I'll be laid up in bed. I won't be going to the dance. I'm going to be in agony. So if that doesn't have a social and psychological and social impact on that girl's life, I don't know what is. So yes, getting the diagnosis of endometriosis, teaching the girls that period pain is not normal and their mum, they go back to their mums and say, you know what, I heard something today at school and my period pain is abnormal. Can we go and see a specialist in endometriosis? And I think that's really important. And then, yes, you get that, you know, the laparoscopy, you decide if there needs to be some excision, and then that's when they get early intervention from a pelvic health physiotherapist who can go through and look at bladder and bowel, because we know bladder and bowel are often affected. We can go through and teach about non-relaxing pelvic floor muscles, or how those pelvic floor muscles are first responders, and they're going to be training all the time to be switched on. And we've got the beneficial effect of letting them go. We're going to teach them about how organs that are close to each other get that response. They get unhappy. If you've got an unhappy organ next to it, they're going to get unhappy. And so that we can do something about what is their constipation like, what is their IBS like. And we are really well skilled at handling that stuff. And what is their bladder like? Why are they going so frequently? And, you know, what is going on with their bladder? So, you know, I feel like that endometriosis is something that we can really start intervening much earlier. And so that's the message we've got to get out, is that painful periods are not normal. Get some education, and this is a pilot program she's doing, and we're having that research talked about at our conference, just to get another plug. She's going to be presenting there. And Rolly Sussex, Professor Rolly Sussex, is actually you won't know him over there, but he's a very well-renowned language person over here. He has a little show on the ABC once a week talking about words and language. It's fantastic. And he's going to be talking about the research he did with Susan on the language of pain. And you know, we all know our words are very powerful. So the language we as therapists use You know, I feel like I mean, and I'm old now, I can say this, but, you know, sometimes we use words to make ourselves look a little bit more important. And so I think, you know, down training our words and our language and using simple language and caring words and thinking, what's the impact going to be of me saying that? Do I need to say that? Can I say that in a different way?
I think that's so important, Sue, because I think sometimes we can get bogged down. We get excited about things as well. I don't necessarily think it's always from a point of ego, but sometimes we do, you know, we want to talk about the periaqueductal gray matter, and, you know, we get excited. But I think, you know, it was Einstein who said that the true mark of a genius is if you can explain something complex to a 5-year-old. And to be
Yes.
able just
Yes.
to work with the person who's in front of you and meet them where they're at in terms of
Yep.
accessibility, but also then just making sure that they're hearing what you're saying, not that it's all in your head or there's something wrong
Yeah.
with your brain, but this is a normal reaction to an abnormal situation, and you
Yeah.
know, you are not broken.